welcome to the Friends of Zeus podcast. This is episode 88. See how I did that? Tonight we have, well, you can find us on all the platforms, some that I don't even know the name. So tonight we have Dr. Anand on. He's a doctor that I worked for at NVMHI years ago now, actually a really long time ago. We wanted to just kind of talk about a couple things that I wanted to discuss was his attitude on how COVID has affected the societal mental health. The one we can probably lean away from was the rationale for legalizing marijuana, and Dr. Anand wanted to talk about the effects of social media on the doctor-patient relationship, which I think is a really, really fascinating aspect of all this. We are doing this as a Friends of Zeus podcast episode, as well as the Nurses Are In, which is the other podcast that I do with the lovely Desiree here. Desiree, oh, can everybody raise your hands so the doctor knows who you are? Tom? All right, Mike? And Des?
And I'm Desiree.
Yeah, she's Desiree, so that kind of gives it away. I guess, doctor, you were interested in talking about the effects, or rather how Google has had a negative effect on the doctor-patient relationship. So I guess if you wanted to kind of lead into that so we can ask questions and go from there.
So I'm going to present a paper on this at a conference because I really am interested in this, and I've been doing some homework on this. And without going to a big history lesson, you know, the doctor-patient relationship has changed. I mean, it's not, in some ways it's changed, in other ways it's very traditional. But let me start with how it's changed. I think in the old days, the doctor knows best thing, and again, I'm not advocating for either view, but in the old Dr. Kildare days, you know, the doctor knows best image was very much one of, you know, an authority figure who knows what they're talking about, who comes from a place of esteemed knowledge, taking years and years, and that was taken as gospel. And the patient was a passive recipient of that knowledge and accepted what the doctor said. I think with the kind of changes in the 20th century with civil rights and the rights of the mentally ill, and then there were associated kind of case law that comes with this, that standard kind of shifted, even legally, to what is a patient-centered standard, which is that basically the patient has a right to make a choice, that they have to know what they're, you know, taking into their bodies, they have to know the benefits and risks, and have a reasonable conversation. You know, not an academic one necessarily, but a reasonable conversation so they can understand like what they're signing up for when they take a medication, for example, you know, or a procedure like ECT. So to cut a long story short, I mean, it's really rapidly changed, I would say, in even the last 20 years with the advent of the internet and then social media. Because there's been an information explosion, as you can all imagine, on the internet, and with the second generation being the social media. And it's kind of what I see as a bombardment of information. You see adverts on the nightly news, you can't avoid them, you know, 4 times, you know, in a half an hour, in between cable news networks, you know, their advertising is just everywhere. So the vernacular language, and I'm talking about mental illness here, but essentially it's everywhere for even all specialties. The kind of vernacular of medical language has just been blasted all over the internet. And you could argue that, you know, that's not been as helpful as you would imagine. I'll remind you that only 2 countries in the world do what we call direct-to-consumer advertising. That's New Zealand and the United States. And you would think on the face of it, that's a good thing, that patients should know about medications and be educated, and that was the idea. In reality, what's happened is that there's been information overload. And I say that because you've seen how fast they read out all the disclaimers and side effects and all that stuff, in a 30-second advert, for example.
Right.
That's just the start. That's just one aspect. But, it's kind of been very alarmist, arguably, for patients, because doctors have to consider these side effects, of course, in their entirety. But first of all, even the courts have said we're not required to disclose every single side effect of every single medication we prescribe, because otherwise we'd be there all afternoon and it would just be discombobulating and overwhelming for the patient. But the problem is that with the internet, there's a couple of factors here. With the internet, there's been that explosion of all these side effects. And you can imagine with patients who are worried about their mental health, their lens as it is going to be affected, or the way they read, an advert or an information post on the internet is going to be kind of tainted because they're already worried. So they tend to zero in on side effects and, what can cause sudden death or cardiac problems. And it's not helpful to them because they'll get anxious. And when you get anxious, as you know, you can get physical symptoms. So what I find oftentimes in clinic, again, to summarize, because this is such a huge topic, but I'll talk about these different aspects. But one of them, for example, in clinic, is that the patient will come presenting with symptoms that they're oftentimes attributing to side effects. And that's a very long conversation because sometimes they're so fixated on side effects that they're scared to even proceed or go up on the dose. And that has been kind of an uphill climb for doctors who were expected to kind of provide the reassurance, but I don't think we're a reassuring ear anymore. Now, that's partly not necessarily all the internet's fault. It's also partly the way that healthcare has been structured nowadays. I mean, people have heard of the 15-minute med check and doctors writing notes and not making eye contact and seeing, 20, 30 patients a day, which I don't do in my practice. I just refuse to practice like that. But unfortunately, that's the way a lot of doctors and healthcare professionals are paid, by volume of patients that they see. So by definition, they're not going to have the time to explain a lot. And sometimes they'll ask questions from a drop-down menu, and it becomes a little bit automated and a little bit dehumanizing. So you can imagine that the trust factor is not there because you're not spending the requisite time with the healthcare professional. And if the patient doesn't spend the requisite time to explain, like, what's going on here? What is this worry really about? What are you trying to ask me or tell me? It just doesn't get to that point, the conversation. They'll get given a form with all the side effects that potentially they can be listed, they'll go to the ER, and they'll be given all these handouts. But that's not really explanation, that's information. So my quest is to find out what happened to the conversation, between doctor and patient. I mean, I think our credibility has been dented by, the system as it exists at the moment, the way we're paid, how many patients we have to see a day. So that's not helpful. But what happens is our role as oracles of information, as I call it, and you think oracles are wise, but the fact is that people will gravitate to any information rather than feeling like they haven't got enough. And that information could be, tainted, it could be exaggerated, it could be distorted. And you can imagine, like, with a patient who's, like I said, already anxious or worried about their symptoms, they literally read it and they'll say, I've got this.
Or psychotic.
Yeah, or psychotic. They'll read terms like that and they'll run with it because their anxiety will make them do that. And the number of patients I've seen, of course, anxiety is so common. But the number of patients I've seen who've gone to the gastroenterologist, who've gone to the neurologist, who've gone to the ER with thinking they have a heart attack because of chest pain, and they all eventually end up coming my way. They won't come my way immediately because they won't diagnose it as anxiety, but they will come my way eventually, and they'll be so information focused, and it's just so unfortunate that they suffer unduly because of bombardment information, and then it's just a blitz out there. I mean, how do you discern what's credible from what's not credible? How do you give a perspective to a patient? Because ultimately they don't trust your authority. And then, of course, with regard to the motives of all the people who put this information out there, you could argue it's kind of fashioned a kind of a consumerist mentality, ideology, that I need this med to make me feel better. I read about it, my friends have talked about it, they've been on it. So they kind of concoct this narrative, which for them is real. I mean, our lives are narratives, aren't they? Our lives are stories.
If I may, how many times have you seen somebody that's allergic to Haldol? When I've done the research, and Haldol really has no allergic reactions. It's like 1 out of 99 people will have a reaction, and it's really not an allergic reaction. It's the reaction that you get from having Haldol. Like,
it's a side effect. Yeah, right. A side effect is not an allergy.
Exactly.
And what happens is it gets reinforced because people rubber stamp each other's notes because of time factors and whatever, and they don't question that. And I know in the state hospital, because we had the time, and because they'd been on medication, and we saw over a 24-hour period that they did not have what we call a typical allergic anaphylactic reaction, where your throat swells up, or you start to vomit, or you get a rash. Now that's an allergy.
Tardive dyskinesia.
Exactly. They'll get the side effects, which are common, which are sometimes like a tremor, for which you can treat that, which is mild. They'll get maybe after many, many years tardive dyskinesia, if they're dosed very highly for many, many, many years. But then again, not every patient gets that either.
Dystonia, I would say, is probably the most common.
Dystonia is, just to explain, dystonia, for example, is like when the eyes start rolling upwards, and it's very frightening for the patient, but it's very treatable, extremely treatable. So you give an injection of a pill, or something called
Benadryl,
and it works. Typically works in that moment, and all things are cleared. So, it's the leaping to the alarmist that makes a side effect somehow an allergy, and it just ratchets up the angst about medications. And really, think about it. I mean, if I read the side effects as a doctor, I wouldn't prescribe anything because it would be so scary.
Some of the side effects are horrible.
Right. Side effects.
They're worse than what you're trying to cure.
And I think Dr. Anand will back me up on this. In psych medicine, it's different than a lot of other medicines in that you deal with risks, benefits. So
we do that with every medication.
Is far better than the alternative.
Yes. I mean, the thing is, it's a question of weighing it up. And many side effects, which again, not explained properly, because it's just, I call it information vomit. They just list every single side effect that could ever happen that's vomited onto the page.
That's the lawyers. That's the lawyers.
Yes. It's horrible because, a rare tumor in a rat is not going to necessarily determine my decision to start Seroquel, for example, which is a really well-tolerated medication at the proper doses for things like sleep, for things like anxiety. It's used off-label, but even for schizophrenia, you gradually titrate it up. So you do the prudent thing. The message, the mantra that doctors learn is start low, go slow. And most doctors do that. They don't go in hot and heavy at the highest dose. Because obviously we know that that's going to precipitate side effects. And the body won't tolerate that. So we do a commonsensical approach. But that seems to be lacking from anything that they read.
Doctor, just so for our listener out there, what is your specialty?
So I'm a board certified psychiatrist.
Okay.
And I've also trained in something called forensic psychiatry, which is basically the law as applied to psychiatry, or psychiatry as applied to the law, which means, I deal with issues such as informed consent, for example, with regular patients. Forensic psychiatry is relevant because you deal with things like informed consent, the right to treatment, the right to refuse treatment, guardianship, malpractice, standard of care that the doctor used. And then there's a criminal aspect, which is psychiatry is applied to the law. So that if people get into trouble with the law and their mental illness is a factor, specialists like me will comment on that in reports to educate courts that, this could be used as a mitigating factor or to exonerate their culpability for a crime. Of course, Zeus and I work together on a forensic unit where patients were adjudicated not guilty by reason of insanity. So their intent of the crime was, wiped out because by virtue of the severity of their psychotic mental illness, so they didn't know right from wrong. They didn't know the nature and consequences of what they were doing.
And
So
may I interject for a second, Doctor?
Yeah.
Dr. Anand, I worked with him I was only there for a year. We've probably touched on it, but I left under less than, desirable circumstances. But I can say that in the time that I've done this, there is another doctor that I work with. I won't say his name just for, the purpose of not having to delete it, but he's pretty good. But Dr. Anand had this amazing capacity for creating these cocktails of the medications that to this day, I'm 5 years in. I feel like I've got legitimate experience.
Of course, experience of it is everything. Of course, yes.
It was astounding. I've not seen it yet. I see a lot of let's throw this at them, but you would do these cocktails of like Depakote and Congentin and Haldol, and I mean, I wish we could go into names because he and I have a history with some pretty hairy patients.
Yeah.
The one that stands out to me is, do you remember? I'll just give kind of a brief history. You remember the guy that I came in with you and we did kind of his exit interview, and you know what happened with him? K.
Yes, go on.
His first name was K. I believe his last name was I. He had gone to Alexandria. He basically shot somebody and got away with it. And we both felt like he was great. And come to find out, like a year later, he got off his meds and they came to his house and things got shady. Do you know what I'm talking about, Doctor?
I've got a vague recollection. We saw so many patients. It's been a long time. But what were the issues you wanted to raise?
Well, I was just, it was kind of just throwing a compliment at you that with proper training and really realizing the medications that you're giving out, that there can be great, like a lot of good that can be done from the medications. I think what happens is, I mean, I don't know why, but they tend to just throw like Depakote, and then they don't mix it with something else where I'm working now. And they do a very good job, but nothing compared to what Dr. Anand did. Dr. Anand would constantly adjust the medications to a point where they were very advantageous for the patients. Like, I got to see a few patients leave the hospital and feel like they were actually ready to leave. And
so this touches on a very important principle, and really it's doing the job in the way it was intended. Like you said, yourself, and I've seen this a lot. You look at a patient's regimen and you think to yourself, oh my God, what were they thinking? Were they throwing darts at a dartboard or what?
Right.
And there's really no rhyme or reason logically why this is combined with this to duplicate the effects or to undermine the effects. And you have to, I mean, in outpatients now, I've had to sort out a lot of messy prescribing because the diagnosis is unclear, and then they're throwing everything else, and it's discombobulated. And what you want to do is use medications for, you have to understand how they basically work. It really isn't rocket science. It really isn't that difficult, because if you understand the basic mechanisms and you titrate it up to the proper dose and the patient tolerates it, like you said, you can see some remarkably, favorable results. You can see the dissipation of psychosis. You can see anxiety chill out. You can see manic symptoms get a lot calmer. You can see ADHD symptoms. I even treat ADHD now in outpatients. You can see things get a lot better, but you've got to know what you're doing. And that's, like I said, is not that elaborate. It just means doing it carefully, knowing what the effects of a medication are, knowing the tendency. Like for example, I mentioned other medications like Depakote or Seroquel, for example. They have like calming tendencies. I'm going to use those deliberately, those tendencies, to help people sleep, for example, because people want to sleep. And and I know psychiatric illnesses don't do well if people don't sleep.
Oh
Ranging
my
from
God, yeah.
anxiety, ADHD, bipolar, schizophrenia. Nobody does well without a good night's sleep. And so I really go after that. And I will use sedative medications to their advantage and gradually go up. I don't want to knock the patient out. I want to calm them down so that I'm allowing them to fall asleep. Of course, they've got to get good habits. They'll blame the medication, like napping in the afternoon and they still can't sleep. Patients do that. They concoct their own narratives because it's what we call self-serving. It suits their, that's how they think about medications. But when you actually give them the totality of information and say, look, if you continue to sleep in the afternoon, you're not going to have a good night's sleep. And they do that because they're escaping or avoiding unpleasant situations, because sleep is used for lots of reasons. I mean, people do sleep to avoid. People do sleep as a bad habit. Teenagers, for example, have terrible habits when it comes to that.
God, yes.
So it's very hard to diagnose bipolar disorder in teenagers. And it was overdiagnosed in the early 2000s, about 8,000% in this country. And then they had to pull back, and the DSM had to be revised specifically for adolescents to create a new disorder called disruptive mood regulation disorder. Just let me talk briefly about diagnoses, because
I'm sorry,
this is
what,
where there's a lot
was that, doctor? What was it called?
Go ahead. Disruptive mood regulation disorder.
Okay.
And again, let me just let you know about diagnosis, because I think it'll help kind of pad out, what we're trying to talk about here. Diagnoses in the DSM are not how doctors are trained. So you remember somebody put up criteria for narcissistic personality disorder for Trump. I'm not going there. I'm just saying they should not have done that, because criteria are decided by consensus of committee. They're subject to change, and they're really not how doctors think, actually. Patients may think like that because they say, oh, criteria 1, 2, 3, and 4, 5, 6, and that means I've got it. You have to be trained to use the DSM, because doctors are trained differently. They're trained to connect the dots for syndromes, not lists. So the DSM has given I'm actually giving a presentation in Paris on the 17th of November on this, called Has the DSM Failed? Because this is really had unintended consequences. Because patients, again, run with it. The criteria seem easy when you read them as a list. And they're really, really not, they're diagnoses, as I said, made by committee. They're not like we know it because it's a microscopic tumor you can see under a microscope. That's not how you make diagnosis of schizophrenia. It's still the old-fashioned way of getting a history, finding out what happened last year, last few months, last few weeks, yesterday, getting the course, the idea of how much it fluctuates over time. Those are the cardinal ways people make diagnoses. Sorry, I didn't want to ramble, but go ahead.
No. And schizophrenia doesn't always present as, the John Nash beautiful mind guy where he sees people. Sometimes it's flat affect. They are delusional. They don't always have the auditory or visual hallucinations that you classically associate with schizophrenia.
Interestingly, you made a good point here, because DSM-4 described different types of schizophrenia. In DSM-5, they got rid of all that. That was a mistake. I'm going to talk about that in my conference talk, because basically they had some really good descriptions of what we call disorganized schizophrenia, simple schizophrenia, paranoid schizophrenia. Those were really valid, because I remember patients in the hospital, you and I probably remember those patients, who didn't walk around with hallucinations and looking crazy. They looked perfectly, what we call normal in their day-to-day function. But if you ask them about a particular delusional thought, they would elaborate on it. But day-to-day, they weren't violent, they weren't aggressive, they weren't bizarre, they weren't odd. They just had that belief. And that was a classic paranoid schizophrenia in the old days. Now, the new iteration of DSM, it's all lumped together. It's all called schizophrenia.
Yeah.
So we went from splitting to lumping. And so the profession goes through its own iterations of like how it wants to classify things. So that's why a lot of these diagnoses are up for grabs. I mean, there's been an explosion in the number of diagnoses. Now we have things like insomnia disorder. Last time I checked, in the way I was trained, insomnia was a symptom. It wasn't a diagnosis. A symptom is but one symptom of another disorder. And so the commonest cause of insomnia is usually, either bad sleep hygiene or anxiety, where you chew and stew and worry about things just before you go to bed, which is a bad habit for many people, and it's worsened by anxiety. But now the notion of an insomnia disorder has arisen. Of course, you had a whole slew of new medications that are being promoted, but can kind of get FDA approval for sleep medications. So we're doing kind of a piecemeal approach to diagnosis and prescribing. It's kind of, frankly, a mess.
Do
I
you
think we're going
say
to look back in this era and say, what the heck were we doing? 50 years from now, 100 years from now, we're going to say, no, we got it wrong. We didn't do that. But we're in this paradigm right now. And of course, when you live in a paradigm, you don't question the paradigm unless you're really a critical thinker.
would
But
you say
anyway, go ahead.
would you what's the percentage, and I know it's kind of a hard thing just to come up with, but what's the percentage split between people who may need to be hospitalized, really have very acute psychiatric issues, versus people that are like, they're looking for like mother's little helper, or they had a stressful day? Like, what is it, like 80-20? Is it like 90-10? Is it 50-50?
I'm glad you asked this question, because this will push back on the stigma. The vast majority of psychiatric illnesses are treated as an outpatient and are fairly benign and extremely common. So anxiety, ADHD, even depression and bipolar 2 disorder, for example, vast majority of those are treated as an outpatient.
Mm-hmm.
So we should try to get away from the stigma that psychiatric illness equals dangerousness or hospitalization. There are, of course, and we were there for you and I when we worked in a hospital, that subset of patients who, of course, come to attention of law enforcement or emergency services because they're simply so out there with the severity of their symptoms. And by definition, that does need hospitalization. But you don't want to generalize from that and say, psychiatric illness is equal to hospitalization. The vast majority is treated as an outpatient, and successfully, not just with meds, by the way. My rule of thumb is 80-20. 80% therapy, 20% meds.
Mm-hmm.
Because a lot of people have ways of thinking, habits, ways of coping with life stresses, relationship issues that have deep psychological roots from their childhood that end up obviously manifesting in their adult life, in their choice of relationships, in how they go from job to job, in how they relate to people. This is the vast majority of psychiatric work. It's actually more psychological than it is even psychiatric.
Yeah. Isn't there kind of a business to it too? I mean, when these ads first started coming on, I noticed them in like the late 90s, maybe the mid 90s, for like Prozac and things like that. And they would have the cartoon, running down the street.
The little
and they have
tomato.
The little tomato, and they have these commercials now where like, you take this pill and all of a sudden everything's like clear. And anyway, I think
wonderful. What a wonderful silver bullet. Yeah. Exactly.
Right.
Go ahead.
But I think there's a split. If people are honest, it's like there are people that are selling something. They're selling an answer. Like when you see an ad on TV or in the newspaper or whatever, you have a problem. Here's the solution. It's very cut and dry. And medicine's not really like that. Like fixing your car isn't really like that. Like how many people take their car into the shop and it's like nothing, like, oh, it's knocking, and they're like, I don't know, it could be this, it could be this. I mean, I'm sure you guys are familiar with that show House. That was so eye-opening to me, because I always suspected that doctors were like just kind of not guessing, but it's a procedure. You have to start with the simple things that aren't really invasive, and then you work your way up. But people don't want to hear that. Like people want to go to the doctor, they want to go to the mechanic, they want to go to the plumber, and they want to get the thing fixed right now. And then if you don't do it, then they say, oh, that's not a good doctor, or that's not a good mechanic.
Exactly. So you have to educate people that, look, in spite of our wishful thinking, wouldn't we all want, with a flip of a switch, to change this aspect of our life? That's called wishful thinking. It comes from childhood. And I could argue that our culture has kind of magnified that tendency. It exists in all of us. Because who wouldn't want to have an instant solution to their problems? It's just not the way real life works. And I think it's more important that, and this is where doctors, if they took the time, could explain, okay, this is why I'm choosing this, and not this. You know, work with me here. I know you may not understand it. Ask me questions. Can make it a thoughtful, what we call iterative, kind of stepwise process. And we're not going to eliminate everything, but we can, just like diabetes, you would manage it. Like we manage the vast majority of mental illnesses quite successfully, actually. Anxiety is managed fairly successfully, actually, if you're prescribed appropriate doses of the right medications, like your SSRIs, which are really successful, actually, for kind of dampening down these tendencies. But then you also then combine it with therapy, which takes time and it takes a certain kind of mentality to say, you know what, this is actually coming from within me. I'm not going to have my doctor do an anxiety-ectomy because it doesn't work that way. That anxiety comes from inside you. Seriously. Freud called anxiety a signal. He called it a signal, not a symptom. And we now think of like, we've got this kind of Star Wars mentality, like zap it and you'll be gone. It doesn't work that way.
And I think, I'm saying, I think also to dovetail on that with psychiatric, and again, you know, we're talking about focusing on psychiatric, but you know, just medicine in general. But if you break your leg, if you're like Johnny Joey and you break your leg and you go to the doctor, like you want your leg to not hurt, you want to feel better, right? And so the doctor says, do this, do this, do this. You're like, all right, I'm going to do this. I'm going to use these crutches. I'm going to take this pain medication. I'm going to do my exercises. However, I think for psychiatry, it's a little different because you probably, and not just you, doctor, but anyone, you're seeing patients that may not themselves know that they are feeling bad or want to feel better, but their family, their loved ones, the law enforcement, somebody's like pushing them in. So the law, so you may not have a willing, I mean, that just seems very difficult because so much about medicine in general, you know, again, if you break your leg, it requires the patient to be in on it, like to be like, I want to be better. Like I want to.
That's the hardest part. That's the intrinsic conundrum, right, with mental illness. Think about it. Your insight. So, for example, I just talked about in my video, like, you know, a hypomanic or manic patient, if you ask them, it's like the Frosties advert, you know, I feel great. Why would they come for help, right? By definition, the manic state puts them in such a state of elevated well-being that they don't want help. Similarly, the anxious patient, by definition, most anxious patients don't trust anything. They won't trust any change, any new plan, any different direction where they can't control. So I try to work with those tendencies in the patient to try to kind of find some hook. You know, that's the art, not the science. That's the art of medicine, where you kind of engage the patient. You did this a lot in your nursing thing. This is what you appreciate as nurses, better than doctors do, actually, because doctors are raised with a somewhat fixed mentality in general. You know, are raised with a very much diagnosis, treatment, prognosis. You know, we're raised with a certain fixed mentality, to be honest. But what we realize after we graduate is that the vast majority of illnesses are not fixed. And you know this yourself, we all know this from our own lives, that the vast majority of illnesses are actually helped a lot more with lifestyle changes than they are with even medications. Like I went to the doctor myself. Doctors hate going to doctors, and I got a slightly high A1C. And I said to my doctor, "Oh God, I don't want to go on metformin, and it gives me diarrhea. I don't want to do it." You know, he says, "Okay, then go swimming." And I did just that. And then he tracked it. The point is, you've got to have somebody supervising to give you some oversight that you're accountable to, that who can monitor your efforts and see what difference it makes. And once you see that, once I went swimming a couple of times a week, my numbers started to come down. And that was really empowering for me. So I often say to my patients, I want to take you from overwhelmed, because typically that's what they are when they first come to see me, to empowered. Empowered means knowing what the medications do, knowing what they don't do, knowing what efforts you make and what difference they'll make. And then we'll work together. I mean, and then it will be better. And you yourself saw this in your, you know, nursing career. I've seen this in my medical career. People do get better if they work with their healthcare professionals and they really keep an eye on things and they're vigilant about themselves. They develop a certain empowerment mentality that they can begin to take care of themselves. Like, for example, the vast majority of people who end up in the ER, the commonest question I used to test the medical students, test them that way. Why do people end up in, what's the commonest reason why people end up in the emergency room? They give all these fancy zebra answers and this fancy name for this. I said, no. And they were like looking at each other. I said, it's because they didn't take their medications. So imagine if you don't take your diabetes medication.
That's for anything.
Right? You know this, right? You don't take your diabetes medication.
I tell
You don't take your,
patients, I'm
Go ahead.
sorry.
No, go
I
ahead.
tell patients, I have like, you get into a flow of things that that work. And quite often I will tell patients, as you were mentioning, I'm diabetic. The difference between what you have and what I have is that if I don't follow my diet, I'm gonna die. I'm gonna die young. I'm gonna lose a foot. a million things. You just have to take your medication so you think a little more clearly. And you gotta take, and I just reinforce, you gotta take your medication. And I tell them all the time, the most common reason I see a patient here on the unit is because they stop taking their medication. And that's not necessarily, I get it, because I think most doctors aren't as vigilant as you are. You definitely, without question, I'm sure that you focused a lot of your study when you were going through school on medication. It's clear. It's absolutely 100% clear to me.
I think we don't appreciate, oftentimes it's hard, right? Empathy is really important, right? So the patient won't tell their doctor, but it's a horrible side effect. And they'll say, screw this, I'm not taking it. That's the most human thing in the world, right? If you don't appreciate the patient at a human level, then they'll basically switch off and not reach out to you. Now, sometimes they'll do that even if you are a good doctor. And I say to the patient afterwards, hey, why didn't you tell me? You could have told me. I could have changed it up. I could have called in a different med. We could have reduced it. I'm on this journey with you. You're not alone, and you need to trust me. And I call them back. So I try to model what a doctor should be with them. I really do, because I do not want a bad outcome, obviously. No. Right? I care about them too, obviously, right? But I want us to do it together, because without them, I can't do it. So then we'll get into a discussion about medications and why they didn't take it and whatever. And sometimes I'll give my famous phrase. I've got some couple of phrases I'll give out and learned over the years. One of them is like, well, you can fool yourself, but you can't fool your receptors, right? In other words, you can make whatever narrative you want, and it may or may not be true, but the receptors will respond to a certain dose, and dose hike or whatever. It is the science of it. And I think that's what people find it hard to wrap their head around, because they're not trained in this area. And so our job is to take that vast amount of information and to distill it into something that's digestible. Isn't that what you want from your doctor? You don't want your doctor to be a lecturer, to talk all these fancy words. Who cares? You're not going to digest it. You're not going to marry. You're going to check out. And then you won't take the med. Whereas the doctor says, look, this is common, but sometimes it's like with SSRIs. Sometimes I'll get a bit of loose stool, but it doesn't last more than a day. Sometimes I'll have a mild musty head. But I tell them, this is the serotonin thing kicking in, so that within a day or so, you'll actually feel a lot better. But take it with food. Let me know if it persists, and we'll take it from there. Like, some people genuinely don't tolerate a medication. So you say, okay, let's regroup. Let's try something else. But we'll find something. Don't give up. And that's what patients do, because they tend to have what we call black and white or all or nothing thinking. Oh, antidepressants don't work. And the first thing I'll say is, well, what was the dose? Well, I don't know. How long are you on it? 3 days. I said, of course it's not going to work in 3 days. But I had a patient today who said, oh, I stopped because the plan was to go up on Prozac, I think by 5 milligrams or something. And she said, well, when I did that, the following day, I did that. And on the day I did it, I felt really bad, so I stopped it. I said, it doesn't work that quick. There's no way you can do that. You were probably having a bad day for 1,000 million reasons, but it wasn't the Prozac, because it just doesn't work that fast.
Doctor, do you think that we're having more cases of things, especially, like, let's just focus on psychiatry? Are we having more cases because we're finding them out now, or is our society and everything causing more cases? Like, just any sort of mental illness. Like 300 years ago,
like ADHD, because that's a big spike.
or 80, like, so 300 years ago, where were all the ADHD people? Like, what were they doing? Were
They
they
were
just
just bad
suffering?
This
kids.
is a very good question. I mean, yes, you're right.
I'm just
You're
saying,
right.
I mean, how is the in other words, is the number of cases going up, or are we just discovering it better now?
The answer is it's complicated. So, for example, when I went to the conference last week, the other week on ADHD versus anxiety, and they can be very hard to distinguish, right?
Mhm.
You know, the experts say, and when you listen carefully, which, that's what you want to do. You want to hear doctors who experience, right? It's a lifelong learning, by the way. We learn from our patients, but we also learn from other doctors, and we learn from research, and we got to put it together in our head. One of the things I learned was, like, for example, ADHD. And I thought it was overdiagnosed, and it probably is. But it's also underdiagnosed in certain populations, and it's misdiagnosed in certain populations. So all the above is true. Obviously, with the push from the media on mental illness, which it definitely came up over COVID, right?
My
There's
mental
definitely
health,
more
my mental
focus.
health, my mental health, it's not good for my mental
The
health.
focus has definitely been more, and the consciousness has been raised. And let's face it, compared to, say, 20, 30 years ago, it's okay to say nowadays, I go to a therapist. Whereas, can you imagine saying that 30, 40 years ago? Probably not the same, right? Not the same public reaction. Prozac, as you know, is the commonest medication prescribed in the world, more than blood pressure pills.
Wow.
So,
Really? Wow.
I always say to my patients, you're in good company, because this is the world's most commonly prescribed medication. And then that kind of normalizes things for them, because oftentimes patients feel alone. So there's that stigma thing that operates on for them not getting help. But now that, that the media has kind of legitimized a lot of mental illness, especially in teenagers, I mean, you could argue that is there overdiagnosis because there's more of them coming forth for treatment or evaluation, and then the doctors may quickly give a diagnosis, but that's the way the system is structured. You have to kind of give a DSM diagnosis literally for the visit, or they won't get paid. So that has contributed to that, but I don't think it's a bad thing that people are coming to doctors. What I struggle with in this era is their essential distrust of the profession, and they place a lot of faith on what they're going to be internet. I find that really odd, and on TikToks, whatever. Maybe it's to see their peer group or somebody else's trolling or experiences, and they believe that. They won't believe, because control trials are boring, right? I mean, who wants to know about, the dropout rate of a control? I mean, that's science. It's boring.
But most people don't have. I'm sorry, but most people don't have a relationship with their doctor. I mean, I had surgery like a month ago, and I've talked to you more right now than I talked to my surgeon in like over 2 surgeries, combined. So you don't really have. Yeah, but I'm just saying, and he's a nice guy. I love him, whatever. But you just don't have that relationship yet, especially with young people today. I'm sure we all get the little thing on our phone. It's like, your internet usage is up 20% from last week, for a total of so many hours or whatever. Kids are on the internet. People are on the internet, on Google, like hours a day. It's just, you just can't fight City Hall. They're getting all these inputs.
Becomes your reality. Think about
yes,
it.
Exactly.
You are what you spend all day doing.
Yes.
Right?
Yes.
I say to patients, listen, I do this every day, all day. Okay? Google doesn't treat a single patient. Okay? Google's not a doctor. I am. Okay? So come to me, because I have experience. It's like trying to drive a Toyota by looking at the manual in the glove box. It doesn't work. Right? It's a two-dimensional experience. So it's a hard sell nowadays, but I feel like if people like myself and other mental health professionals start speaking up, because do doctors lobby Congress? Not really, because we're busy seeing patients. It's drug companies and insurance companies and other stakeholders that are always interfering in, like, I prescribe a medication with a number of refills, but it's denied because it doesn't fit an algorithm. And then the patient comes back to me and, can you call my pharmacy? And all those inconveniences of the healthcare system, which I typically say, I've got my workarounds for the system. I mean, I think everyone does. All right. So what I do exactly is I call the pharmacy and I say, listen, I prescribe generics, for example. So that takes half of it away. But I had this prior authorization form, and I hate filling forms. We all hate filling forms, but I especially so because it interferes with me spending time with the patient. So I said to the doctor, I said to the pharmacist, so how much is this generic? What happens if they paid for it themselves? You know, because I don't want to like give them 90 days. That's too long. I don't know how they're going to respond.
No,
He said,
no,
they'll pay about 12, 13. They'll pay 12, 13 bucks. I said, I'm not filling out that form. They can pay 12, 13 bucks.
Yeah.
Okay.
That exact same happened to me with,
But that
with one of my
algorithm,
medicines.
it was very telling because it was an algorithm for the insurance company because you're a number for them. You're 010101. It's that binary thing going on. So that's
It's a
what,
business.
unfortunately, the system is. It's dehumanized patients, and patients have unfortunately got pulled into that cyber world whereby they think that that's reality. It's not. If they spend time talking to their doctor, that becomes their new experience, and then they tell their friends that no, there are good doctors out there who do care. You know, there are good clinics, there are excellent nurses within the system, but the system itself is very dehumanizing and robotic, algorithmic. It's awful. It's just awful. You know, so that is what we have to push back against as a profession. You know, I'm going to argue in my talk that the American Psychiatric Association should lobby government against having the drug companies advertise so aggressively to patients.
Yes.
Because it's an unhelpful consequence of that. It actually alarms and it actually destabilizes and makes patients really anxious.
It
and
doesn't
that's not
help.
helpful.
It doesn't help.
Right. You can advertise to me. You can bombard me with all the terminology because I know it. They don't. How can they know it in 30 seconds?
This is the part. This is the time on the podcast when we go to Tom and see what Tom's thinking.
I have a question or a comment.
So anyway, I can ramble on and on, but you can see
No,
where
I'm just curious because I just didn't know if Tom had a point or something to throw in there.
This is fascinating.
Yeah, it is.
Go ahead, Desiree.
If you go, so of course, the things that are like, you know, impeding the doctor-patient relationship. So one thing we have is
tell
the
them
internet.
what you do is.
Oh, okay. So I am a nurse. I've been a nurse for almost 9 years now. I work in the cardiothoracic intensive care unit. So we cover hearts, things like that. About to move into the ECMO specialist role here at my hospital when we become a regional ECMO center. So we do a lot of different things. But the themes are the same. Like, so this whole Dr. Google, you know, thing. And then also I think a lot of this mentality of the patient is always right, or the patient directs their own care, or, you know, even in combination with the holistic, you know, self-care that people do, you know, I think it also stands in the way of having a good doctor-patient relationship. There's been many times where, you know, patients come in like they didn't take their medicine. Well, or let's take an easy one, Lipitor. Okay. So they say they have an allergy to it, and it's like muscle cramps. Okay. Well, that's not an allergy. That's actually just something that happens. That's why you take it at night. Did you take it at night? No, I took it at day. So you didn't follow the directions. No, because it's easier for me to just take it in a day. Okay. Well, do you think your doctor's maybe telling you this for a reason? Like, no, but I just didn't want to. Okay. Well, that's not there's instructions for reasons, like maybe follow those, or patients that, you know, think that they want to do something completely different or go a different route or go to 5 different doctors for the opinion because they don't agree with what the first couple said because they want the answer they're looking for.
Of course. So so you touched on a point I made. I actually got a subsection in my talk says, you know, give me what I want, doctor, otherwise I'll write you a bad Yelp review. Right? So this is what we've become, you know, and you see in some clinics, you know, how are we doing? Please give us a good reference on Google or Yelp or whatever. I have never subscribed to this customer service model because it's so asymmetrical, right? You've got the patient's knowledge on one hand, and you've got the doctor's and the healthcare professional's knowledge on the other. And there's a vast difference. You know that because you've been trained, right?
Yeah.
I will never subscribe to the customer service model. What I will say is this, that I will do things in your best interest because I'm ethically bound to do that. If that means telling you what you don't want to hear, I'm forced to do that because I'm trying to help you in your best interest to make a decision that it will help you ultimately. If it's not what you want, that doesn't mean I'm a bad doctor or that you're right. it means that it is what it is, right?
It's like being a
It's hard.
fiduciary. It's like being a fiduciary, right? I mean, it's like, in other words,
yeah.
yeah,
I'll lie in the road rather than let my patient get struck by a car. That's what a fiduciary duty is.
yeah.
And accountants are supposed to have that, and lawyers are supposed to have that, and certainly doctors have that, and nurses definitely have that, of course. So I think the fundamental ethics have been lost. Of course, they'll be the first to complain, and there'll be complaints and this and that. And this complaint procedure is, very upsetting and anxiety for even for healthcare professionals because they keep put on the defensive. But what it's a reflection of, I think, is unfortunately an entitlement mentality that's been fostered by that customer service thing. It goes the whole turf with the advertising, the instant gratification. You can have it now. Talk to your doctor about this. It's not talk to your doctor. It's tell your doctor this.
Yep.
Yeah.
Ask your doctor for this.
Yeah.
Right.
It's
In
horrible.
other words,
It's horrible.
We're supposed to rubber stamp what you want. That was never the deal.
No, and it's you can see it in practice. I mean, you have patients that are 85 years old that they don't care. They're going to do whatever the doctor says. It don't matter.
I know.
Because that's what the doctor said.
Yeah. Yep.
Mm-hmm.
And they're the opposite. They're the passive recipients, and they don't even complain. They're so stoical. And they reflect societal values, right? I mean, they've changed. In some ways, it's good that you empower patients. In many ways, it's good that you educate them and they know, and they ask intelligent questions. I want that. I want that level of discussion. I want to take it to that level.
Sometimes so you can't count on that. You have to. I'm sorry for interrupting. You have to weigh the level of autonomy that you provide them with. I've got a weird perspective on providing, much like Norplant. Like sometimes I feel like with certain patients that have the capability to make an educated decision, that some form of Norplant, where it's a time released medication that they have in their arm that goes over like 4 or 5 months and constantly keeps them medicated, takes away some of the stress of, did I take my medication? Should I take my medication?
Agreed.
Or actually, it doesn't matter. I'm taking the medication anyway. It's bothersome to me because I feel like you take away their autonomy, but in the same right,
do they have the autonomy to choose to have it put in?
Right, and that's the point where I feel like it should be done, but it is a tough decision because you're asking them to do something that can last them years. But I feel like it's not going to get any better if we don't get these patients medicated on a consistent basis. And a monthly shot, man, I can't tell you how many times I've had a patient that comes in and they didn't take their monthly shot and they're back to square one. And it's
that's why we have to kind of reintroduce the credibility of the science. Like your autonomy, your body doesn't care about your autonomy. It'll respond to whatever's in it. In other words, if the medication's in it, and it's been proven, of course, with depot medications, antipsychotics for psychiatric patients, right? If there's an adequate, consistent blood level, the symptoms are typically much more at bay. Okay?
Absolutely, like Depakote.
Year after year, every study, controlled trials, everything. That's why they're out there, right? The hoops that they've had to jump through. The FDA's hoops are actually quite high, right? You could argue about whether the relationship with the drug industry is questionable nowadays, but by and large, I still want to feel like I can trust the FDA for making basic scientific decisions because there's a lot of very, very intelligent people at that level, right? But the point is, we have to be able to convey that to the patient that, look, you can do what you like. It's the same thing about the receptors thing, right? You can say you can fool yourself, but you can't fool your receptors. Like you can do whatever you like, but you're going to be back here again, and it's up to you what you do. And I try to give them the choices to say, look, if you're not ready to do that right now, it's okay. What I'm saying to you is that the longer this goes untreated, the harder it becomes to treat.
Yes.
And you can go up and down and up, chop and change, because I've seen so many chopping and changing. This is where our profession hasn't helped with the prescribing practices, that they don't dose things up adequately. So someone will say, oh, Zoloft didn't work. I don't know what dose, like I said. And they were on like 25 milligrams, the lowest dose for like 4 years, because a primary care doctor would rubber stamp that, prescription. And that's just a function of how busy they are. They don't think through that. I think if they thought about it, they know that that's not adequate dosing. And they're taught that. But they somehow forget that in the busyness, as it were, the business or the busyness of life, seeing lots of patients. But explanation makes a big difference. You say, look, this is what I tell them. This is the information. I respect your opinion, but I'm just telling you from my experience, if you don't take it, it ain't going to work. If you take it improperly, if you stop and start, your blood levels will be all over the place, and then we'll be right back where we started. So let's do this properly.
Yeah, like
in the way that it was intended.
I'm sorry, lithium, for instance. If you have a high sodium diet, lithium does like nothing. Or it may be the other way around, low sodium diet, but lithium is a salt. So if you're taking, I want to say it's high sodium diet, it diminishes the effects of lithium.
Yes, it does.
But
it does, because then the lithium gets spat out by the kidney preferably over the sodium. So,
if I may, I've been on not a lot of medications. I've been on sertraline or Zoloft, Prozac, and I'm the anomaly in that I got on buspirone, and that has been more effective than anything else I took. That's the other interesting thing about these medications is one medication, what works for one person will most certainly not work for the next. Buspirone.
It's amazing the variability. Yeah, absolutely.
Do you, sorry to interrupt you, just on that thought, do you find a lot of, have you started utilizing a lot of the, like the genetic testing where you can see how certain medications are metabolized, to see which one's a better fit for a patient?
It's gaining traction, but it's, again, the public thinks of it as a silver bullet, right? All it does is it'll say, for example, if you're a fast metabolizer, it means that you're likely, that's why the dose you're getting, which we thought was a good dose, is actually too low. So it'll guide the doctor for patients who had this medication, that medication, this didn't work, that. So yeah, there's a role for genetic testing, and it's gaining traction, and I saw that at the conference. These companies basically help you out with that. Of course, they want to make money out of it, but that's a good cause ultimately because it gives you a breakdown of their liver metabolism. And that's really good data. So that is helpful for patients who kind of feel like nothing works. And you can find an answer to the question, why? Well, because this particular enzyme, your genotype, means that this enzyme's not functioning adequately. So, you probably will need higher doses. Or if it's over-functioning, right, you're more likely to kind of you get side effects and things like that. So there is a science here to that. It's gaining traction. It's not quite what I call a standard of care yet, but patients, interestingly, will bring those results from another doctor to me, right? To say, they'll shove it under my nose and say, hey, this test, because they've got these nice little blocks. Of course, the corporates are really good at that, right? So they'll put green, orange, red, and of course red is don't prescribe it, and that's too absolute, right? That's way too absolute, and that's too simplistic. And of course the patient runs with it. Of course they will, because it's another silver bullet for them. I'm like, whoa, no, it doesn't work that way. We have to see how it works in your case. But yes, it's a guide. For me, it's a red flag. And let's take a look at the meds, and let's maybe steer away from this and try this instead. So it is a guide, but I wouldn't use it as gospel.
No, so back, it's just interesting because with the buspirone, I had one doctor describe it to me as it's like farting in the wind. It doesn't have an effect, but I found that it gives me, and honestly, the gang here, besides yourself, doctor, pretty much knows that I have situational issues that cause more of my, I don't even know, I guess anxiety, depression. I'm not sure what I've got going on, but
You remember my 80-20 rule? Remember my 80-20 rule, 80% therapy, 20% meds? The vast
You need
majority of
therapy.
people's anxiety can be made worse by how they handle it in the moment or by reflexively resorting to certain ways to cope that they're not conscious of. So they end up perpetuating the same thingies. And once you become cognizant of it and pull back your thinking from the kind of jump to conclusions or reflexive thinking that this means that, for example, at the CBT model, then you can basically modify your responses, and that will change the outcome, of course. So therapy is really important in the case of psychiatric patients. More than it's being debunked now because we're raised with what we call the biopsychosocial model. Last time I checked, it's bio, right? Which is all meds. And that's really what's happened. And it's really unfortunate. It's distorted the comprehensive appraisal of what's really going on. Like when people get angry and they'll say in the middle of an argument they want to kill someone, that doesn't mean that they deserve to be hospitalized. Okay? This thing about suicidal ideation. Yeah. This thing about suicidal ideation, I went to one talk at a conference. This whole suicidal ideation mantra that you ask the patient if they're suicidal or not has absolutely no validity at all.
Well, you're also giving them a very you're also giving them a very binary answer, yes or no.
Yeah, exactly. And they're not going to tell you if they're suicidal.
Have you ever wanted to kill yourself? Well,
of
yeah,
course.
once, but I mean,
of course, everybody can say that. And if they're intoxicated in the middle of an argument, it's heated, they'll say things they don't mean. That doesn't have any implications for suicidal risk, unless, there's an established history. This is where the forensic training comes in handy.
Yeah,
they've got an established history. They're not even just a plan. They're actually in a state of mind. The way one of the experts was talking about something called a suicide crisis syndrome, whereby they won't say they're suicidal, but they're so agitated, they feel like they have no choice. They don't want to be hospitalized. They'll tell people what they want to hear, but they will be basically in agony, and that is intolerable for them. And yeah, suicide's a way out in those kind of intolerable states.
It's almost like a fight or flight.
Sorry?
It's almost like a fight or flight reaction, rather than the actual ideation. It's like I'd rather die than go.
Right. The plan thing is if you have a chronic, undertreated, forever years, your thinkingness is so dominated by kind of negativism that you don't see any hope. It's understandable that people who have long-term depression and who don't get properly treated. And so they really don't see, any other avenue. And so then they start to think about it, they chew on it, becomes a reality, they start to rehearse it, plan it, then they go to Home Depot and get the rope, right? But there's a long stage between ideation and going to Home Depot and getting the rope. And if you can catch someone anywhere in between, you can intervene, right? I tell people depression is so treatable. Yes, we talk about treatment-resistant depression, but the vast majority of depression is treatable. So if you knew that, and that would affect your judgment, and that would affect your decision-making, why would you not why would you not intervene aggressively to treat the depression? Their whole world changes because of that. Their thinking, their decision-making, their outlook, their appraisal of the situation is totally changed.
If I may, not to mention that we're in this medical society, I guess you could say, where we're not given the time to validate what they're saying. It's something that I really work on all the time. Is I get what you're saying, and sometimes it's nonsense. Sometimes it's just what they've said to get the med that they need or whatever. But I feel like patients are not validated nearly as much as they need to be. Even in the nonsense that sometimes they may spew out at you, you can grasp onto little fibers of what might really be the cause and then go from there.
This is what I love this bit, because the way that it's oftentimes handled is you can see their affect, their irritation, the demandingness, whatever you want to call it. It's building up, right? And you'll have this deadpan answer from a lot of people, administrative kind of answers, so that's not appropriate, and all these intellectualized answers. And I can feel this building up in the room, and I'll say, what's this discussion really about? What's going on here? Right? Because you can see that they build up a certain animosity, or the trust stuff from previous encounters is kind of thrown up in your face. And I will say to them, I'll comment on the affect in the room, and I'll say, whoa, this is getting heated. What are we really talking about here? Is it that you don't trust what I'm saying, or is it that I've disappointed you, or you don't have any hope? Let's talk about the feeling behind all this angst here that I'm feeling. I oftentimes comment on that's a motivational interviewing kind of technique that we use is to validate the value systems that they have, right? You feel you should be able to eliminate your pain completely. Is that right? Yes, Doc, of course. I see. So that's where you're coming from. Can I educate you about that? Because I agree that pain can be intolerable. I agree that no one should have to live with pain. But if there are some conditions that we can maybe reduce the pain, and being realistic with you, so I don't give you false hopes, but giving you realistic hopes that if you do this, this, and this, it will make a difference. You know, there's a way to count the conversation, right? It's a skill set. I'm sure you know this is. I think medicine and nursing is more of an art than it is a science.
Oh, absolutely.
Mhm.
It's how you do it. It's not what you do. It's how you come across. Do you come across as if you care? And it's been borne out by studies, right? Patients don't sue doctors, who, even if they made a mistake, if they know that the doctor cared about them, or if he's trying, or he's making an effort, or he's got the humility at least to relate to them, right? They'll sue people who come across as indifferent, intellectualized, rigid. It's a human interaction after all, right? So that's what I'm trying to argue for in terms of the doctor-patient relationship. This is a relationship. I often say to the patient, at the beginning, I say, this is the beginning, it's not the end, okay? I'm on this journey with you no matter what. I had a patient the other day whose meds were not working. I was trying to get them off benzos, and he was saying, oh, nothing else works. And I said to him, you know what? Maybe nothing else works. Let's have the benzo. Upon having to battle with him about it. He had been on benzos for decades. And we were graduating off it. People can get withdrawal symptoms months later, years later. They don't look at the textbooks. And I said, you know what? I tried this approach. In your case, maybe your body doesn't like it. So why don't you go ahead and take 2 Xanax tonight? And let me know tomorrow what happens. Because it builds a trust, right? That you still care about them. And that, look, you'll try an approach. Because it's not unsafe. It's actually unsafe if I stopped it completely and then he maybe has a seizure down the line.
It's a pick your battles. Pick your battles situation.
Pick your battles and respect the science of medicine. If I had stopped it completely and been rigid, no more benzos, he could have had a seizure about 2 or 3 days later. So I thought about it and said, you know what? What's the harm? It did work for him. He's saying it works. I'm going to listen to him. We're going to cut this down and maybe add this later. But for the moment, if he's that anxious, let him have the benzos.
And for what it's worth, I'm sorry. And for what it's worth, with and especially with mental patients, again, it's a quality of life because, for the most part, we're getting them 18 years in, unless you're an adolescent, psychiatrist. You're getting them after they've had a wealth of either poor medication or good medication with no CBT, cognitive behavioral therapy, or just a million things. So you're kind of picking up late in the game where they may have been on benzos, even if it's like, 0.5 of clonazepam, it's still a benzo.
That was a dose, actually. Go ahead.
Yeah.
That was a dose. It was tiny, but for him, it was everything. And his body was getting tremors and sweats and, sometimes they confuse. And I did say to him, I said, your anxiety about the anxiety is obviously escalating, but we'll talk about that later. For the moment, let's break the cycle. So yes, you pick about, but this is an interesting point, actually. It's about, you said that they've seen countless, had bad experiences and stopped and started and other doctors did this, Here's what I want to say to that. If you're facing a patient in front of you, can you be the corrective emotional experience for them? After all, our profession is tainted. For whatever reason, it's tainted, right? They don't trust doctors.
Yeah, it really is.
I'm seeing of them. Why don't you be the one doctor that they can say, you know what? He may not be able to fix me, but he cared about me, or, he connected with me. And I called the patient. I called him 2 days in a row, and I asked him to call me 2 days later. He was so grateful that I called him back. it's gestures, right, that show that you care. The
And they're
gesture
not,
was that, hey, what's going on here? You know what I
and
mean? Go
and
ahead.
they're not like these inhuman just meat puppets that just walk around and have no thought process or no desires, needs,
They're
wants.
humans. They're human
Yeah.
beings.
But
They're human beings who are frustrated by their experiences.
yeah, from my experience, 9 times, I mean, Dr. Nan, I don't know if you recall, but in the time that I was there where we worked together, I gave one shot, and that was to SG, and I'm sure you recognize those initials. That was the
Right.
only shot that I gave the entire time that I worked there. And for you guys that probably aren't as familiar with this, one shot in a year on a behavioral health unit is unheard of.
Yeah.
And I was pretty proud of that. Now I have changed my attitude, and I work with a far more acute unit now, and we give far more, but I probably still, in the 4 years that I've been away from where we work, I probably still only given like 20 emergency med shots. I always give them the opportunity to take the pill. For me, it's all about autonomy. Give them every chance to make a bad decision.
I agree with that. I agree. Why not give them the choice, build the relationship, and roll together, right? I mean, we know that in emergencies, when someone, and you've been there, I've been there, in absolute emergency, when someone's smashing the place up, they're yelling and screaming their head off, they're totally out of control, you need to intervene, because the other side of the coin is, and I saw this as well at our facility, right, was that if you let someone continue to escalate, that's actually very, very unhealthy, because verbal aggression leads to physical aggression inevitably. It really does. You don't want to be too trigger happy and intervene too early. You want to be able to do what you did, which is like offer them a chance, try to de-escalate, use your social and, your nursing skills to try to kind of connect. But if it goes to a point where they're just simply not even there, you've got to go in and reduce that arousal. That's the brain arousal, right?
My rule is when they're a danger to themselves or others, then I'm fine with it. Outside of that,
Exactly. You'll know that.
Yeah, as long as I'm keeping them cool and talking, there's a chance that I can get them to take the PO, which you can attest to this. There's like a 5-minute difference in how quickly it affects you. There's not a massive difference between getting an IM of a medication and just taking it PO.
Not if you do it IV.
Well, okay.
Do a lot of your patients not have IVs?
Yeah.
IV is very fast. IV is very fast, of course.
But that's obviously not a realistic, well, but she was joking, so we don't need to go into that. But yeah, no,
these routes exist for a reason, right? I mean, in psychiatric emergencies, most of the time you can de-escalate them. You may not even need the meds. It depends on the nature of the emergency, right? You have to get, that comes from your own experience and judgment, right? If someone's clearly manic, they're not going to be de-escalable, are they? I mean, if they're out of it, and we've been there with patients, it's going to just prolong, and they're going to go off on tangents, and you're just not going to connect because they're just simply so severely ill. That's when you have to intervene, just make a decision. Like, do we intervene because you can see how it's on a knife edge? They could blow at any minute. Now that's a judgment call, right? But most of the time, like you said, it's not at that level. It isn't. I mean, emergencies are relatively rare, let's be honest, right? They happen. They're part and parcel of being in a hospital. But if you can, and I'm only speaking about psychiatry right now, I'm not talking about the other specialties. If you can, of course, it's preferable to have what we call a lesser intrusive method for, engaging. And if that means having a conversation, what could be easier than that? If it's properly done with proper careful skill and respect and all that. Who wouldn't want a patient to engage without having to do all that procedural stuff, which affects your alliance later on, etc.? It's not good.
No.
But when I saw patients who were allowed to just like let rip, and then the arousal level was like getting higher and higher, that was a mistake. You need to intervene earlier for that.
Switching gears a little bit, but kind of also slightly related. What do you think of things like BetterHelp and Cerebral? this online therapy services. Cerebral, I think, I don't know if BetterHelp does it, but Cerebral even does online prescription medication prescribing.
I don't. I'll tell you my experience of it. I did online medication management, and I know people who did online therapy.
And I'm not saying like COVID related. I'm saying like.
No, I'm saying that I don't think it works because you miss so much information. Your interpretations, your verbalizations, your non-verbals, verbals can be so misinterpreted. It's not helpful. The number of patients who've told me that they don't like online therapy, you know, because they're now back in the office with me, right, is immeasurable. I mean, it's not how therapy was intended to be. It's convenient. Here's where it's really bad. Teenagers, adolescents, they're hard enough to engage as it is. They have bad habits. They're smoking the reefer. They open up the laptop. They go, yeah, you know, breathing techniques, yeah, for my anxiety. They close the laptop and they go back to the reefer. Because think about it. Look at the symbolism of the opposite, right? Of driving to the office, sitting in the waiting room, then talking to the doctor, then going out of the office, getting back in the car with or without your parents, right, and driving home. There's a huge symbolism in that. And
well, it's
in
an
terms
investment. It's an investment of your time that actually.
It's an investment of your time. It's an effort. And as we know, it's an effort to change your thinking. It's an effort to change. And I think this push on, you know, the typical corporate push. This is easy. Just press this button and you'll get a therapist in seconds.
Yeah.
Well, the quality is not good, but the messaging is terrible for that because it undermines what therapy actually is. It's not like, you know, when I have my patients and I do an online thing and I put in a cup holder. I'm in a cup holder in the car, okay? And I say to them, look, I'm not doing this, okay? This is not respecting the sanctity of this. This is not appropriate. I'm not in between meetings here. This is not appropriate. Why don't you park the car, find somewhere private? I had someone who was literally outside a shopping mall and the wind was blowing away and I was on FaceTime with them. I'm like, what is this? I said to them, I said, I can't do it that way.
Yeah.
So
you have to have some investment.
Because of the technology era, they think that easy equals good. It's not. You know, easy and convenient. I'm not a cup holder doctor, okay? I don't
and that goes across
that way.
Yeah, that goes across a lot of industries as well. I mean, people, again, they don't want to make the investment. I mean, it's like, oh, let me get in my horse and buggy and go to the doctor's office. I mean, things that are new and things that are technologically advanced are considered better just by default, at least, you know, in our society.
That's such a mistake. That's such a mistaken core belief. That
Exactly.
It's better or good.
No, but it's
not
the way it is. I mean, a lot of people feel that way, especially younger people.
Yeah,
I mean, you just see it. You just see it in our culture. You see it all the time.
It's like Google influence of fast food. Everything is now. I don't have to know anything about you know, neuropeptides. I just need to look up neuropeptides and get a base amount of information from it, you know, and then I'm good. I back to what Dr. Anand was talking about from the beginning is, we're in a bad place where people that maybe need a little more guidance in the information that they gather are still quite easily able to gather whatever information they need from the internet, regardless of its validity or the intent of the person that's providing the information. It's a frightening place. I full on agree that there needs to be some adjustment with how information is relayed in the aspect of mental health. And I think in some ways things are getting better, but I think overall we've gone much further into the medicinal answers. Like, honestly, like, I'm taking the Buspirone. I'm going to stop taking it because I know what my problem is and I know how to solve it. And the medication is just something that I was doing to make myself feel comfortable. I am an anomaly. I firmly believe that I do not need medication.
Well, I think that's what a lot of people think too. They're like, I don't need this medication. My body,
Right,
whatever.
but I'm pretty darn confident. We all know what I'm talking about. I know what I need to do to relieve myself of a great deal of stress. It's just a matter of doing it. It's not the medication.
And there's no harm, and there's no harm in you working on that, like every human being has to in their life to grow, right?
Yep.
I'm saying that the role of medication is kind of like, for me, I tell the patient, look, the reason I'm prescribing something is because I want you to get back to first base. I want you to be functional. I then want to zoom right out of your life, because you have to pick up where I left off. Because without the medication, you're going to be too anxious, too depressed, too this, too that, to be able to even engage in therapy. So, but that's the kind of patient I see. If you've got lesser degrees of interpersonal issues, anxiety issues, actually it's been shown that therapy is as effective as your Prozac for milder degrees of depression and anxiety. It really has been shown. So it's not that medications have this crowning, role that they've been put on a pedestal like they have in our medication culture. I think we've really given therapies a short shrift, because therapies take time.
They're not as easy as a pill.
Introspective, right? You have to do the work. You have to then have the feedback, and then the feedback loop with your therapist about what worked and how you tried and what was the situation. And that changes brain circuitry just as much as the medication does.
You got to look at it like wiring for like a computer from pre-Y2K, where it was hardwired like pieces of metal, and all it did was this thing and that thing, versus what we have now, which is a far more intricate computer system. You got video cards, you got RAM, you got all these other things, and now you have all these other aspects that you have to address to get your computer back to where it needs to be. And
I say to my patients, this conversation is changing your brain circuitry. Remember the Back to the Future movie? What we're doing now is changing the future. Because, most anxious people worry about the future. Well, what's the best way to change the future is how you handle it now.
Mm-hmm.
Exactly. Change the present.
Right? Change the present. And the orientation oftentimes of some anxious people, or many people, is so future. They would create these narratives, these circuits that take on a life of their own, and they live in them and they feed them. And I oftentimes say, I'm asking you to do less work. I'm asking you not to feed it. Just don't feed it. It'll come. It'll go. This is the whole mindfulness thing. These are people get impatient with.
Don't look for the anxiety. It'll find you.
Sorry?
I think one thing too.
Don't look for the anxiety. It'll find you.
It'll find you. I think one thing with therapy too that a lot of people don't think about is, if you're seeing a therapist, it's not like if you go to a doctor because you broke your leg and you're going there to fix your leg, they're not looking at your whole skeleton. Well, you can do that with a therapist as well. Like, just because you're going to see a therapist doesn't mean that they're dealing with every single thing in your whole life. You could have one specific thing that you want to deal with, and talk to the therapist and deal on that one thing.
Are you talking to me,
get
Mike?
Past it. No, I'm just saying in general. I'm just saying I saw a therapist one time for one specific thing, and it was like a bridge over a chasm, right? And once I got to the other side, I was like, thanks a lot. That was great. And everything, on that situation was good after that. It doesn't, in other words, I guess what I'm saying is you can target things. It doesn't have to be, this all encompassing, I just generally don't feel good about something. It could be something very specific. And I don't think people take advantage of that as much as they could.
Right.
Wow.
Right. And it's the purpose of a therapist to educate them about that. I have a lot of young men I see in my practice right now, and they're just lost in terms of career direction, identity, girlfriend, socialization. And I was saying to a patient today, for example, I said, well, what is it you need? He kind of looked at me. I said, well, you all have needs, right? You may want sexual relationships, but do you need it right now? You know what I mean? So I just try to put it back to him to say, this is not a medication issue. You have to figure out what your needs are and ask about that. It's your therapy. Go ask for what you need from your therapy. And they'll try to help you. I can just tell you as a doctor that you're trying to figure out your identity is not a medication Prozac issue, obviously, right? You might get anxious about it, but it doesn't seem to require, you don't get panic attacks about it, right? So I don't think I need to intervene with a med, but you certainly need to use someone as a sounding board. We all need that. So you kind of couch it to the patient as to what the role and value of therapy is. And I think a lot of them will respond to that if you do it carefully, intelligently, like as if you care about what they want, right? I often going to say, what do you want of the meds? What do you
Goals
want
of care.
I think the thing you said that is most important there is you gotta care. Like, you know what, man, I work with psych nurses that are there for the job, and I work with the psych nurses that are fascinated and always thinking outside the box, looking for different ways to solve the problem. And they're so much more important than the ones that are just there to hand out pills and give the textbook answer to a problem. I can't even tell you how many times, and you've seen it with me, doctor. I don't handle things on an orthodox basis at all.
No.
I am, hey, brother, let's just calm down. Let's talk about it this way. Let's talk about
You're very relatable. You have the quality. Yeah, you need to have the qualities to do this kind of job because you have to be relational. You got to like people. You've got to understand people. You've got to be able to talk to people and have a kind of a back and forth, not an argument, but a real engagement. I mean, that takes a certain quality of person. If you're just doling out meds, then you're perpetuating all the distrust of the system. You know what I mean? It's just, that's not what it's about. So we have to be ambassadors as well. You know, be the change you want to see in the world. I mean, I try to be an ambassador for our profession because it's the only time they get to see us face to face, right? So it does matter.
I got to tell you, you're still crushing it, doctor. No, I mean, I told everybody, I was like, you know, before the show, I was like, you wait till you guys talk to Dr. Anand. He's going to blow your mind. The guy really cares about what he does. He puts forth
thank you so much for that. Here's certain basic values I always subscribe to, and I've been very, very much wedded to my values. What are my values, right? I don't want to churn them and burn them. I only see 6 patients a day, and I take lots of breaks. So I take care of myself. I go and work out. I can't give authentic advice if I don't live it, right? I felt at the hospital I was quietly dying inside because we were going to mandatory trainings. We were being herded from this meeting to that meeting, which were fairly meaningless, to be honest. You know, and it's just the way the system rolls. It's not the fault of the people. It's just the system has become so bureaucratic and, you know, rules for the sake of rules kind of thing. But what I've done in private practice is you're allowed to kind of do it the way you want to do it. And so the way I do it is I spend sometimes 2.5 hours with a brand new patient with a family. I remember trying to see a whole family in an hour and a bit. And I was getting a thumping headache because the kid is like shrugging his shoulders, I don't know, flanked by both parents. I'm like, this is not working. So what I did was for example, I spent 1.5 hours with parents just by themselves. They'll give me the intellectual history. We'll have a banter and discussion about this diagnosis and this thing and parenting, all that, without the kid there. And then I have the I don't know session where, you know, they're shrugging their shoulders, but at least then I'll bring in the family and say, look, this is what mom said to me. This is what, you know, what do you think? I mean, I want your buy-in, blah, blah, blah. And I'll take 45 minutes with the kid and the family at the second session. And only then I'll bill for the initial patient evaluation, right? And so the point is how you structure your approach. It doesn't have to be a one-size-fits-all. Unfortunately, like many people don't think outside the box. And this is the great thing about our country. I mean, you can do it any way you like, within reason, right? But you can do it pretty much according to your style. And I find that style has worked for me because I'm less stressed. Therefore, I'm giving much more patient attention to the patient. I am not thinking of them as a number or as a ka-ching or a billing code because I'm having breaks in between. I'm laughing with the secretaries at the office. I need my chocolates, I need my coffee and all that. So you try to make a day that's fun and productive for you. I mean, in the widest sense of the word, not in a material sense. And I feel like because I do a good job, the referrals keep coming. But that's the way I structure it. Not everyone does it that way, and not
Well-
everyone has the luxury of doing that way. But that's what I think is lacking in our system.
Yeah,
We
it's
spend more
well.
time.
I mean, you put the. I mean, I use this analogy all the time, but you put the oxygen mask on yourself before you go to help other people, right? I mean, it's like when you're in the airplane, you got to take care of yourself.
If you're not being authentic, you're not connecting.
You're not connecting.
Just be authentic, be real, be human, and stand your ground. But I think patients respect your authenticity, even if they disagree with you. They don't, this is what I believe. I've done this for years. I've done this for 30 years. This is my experience. I've treated thousands of patients. I can help you. I really know. Let's do first things first, next things next, last things last, because it can get confusing. So I try to kind of meet them, at a very basic level. To say, look, I'm here with you. I'm going to hold your hand in the beginning. And then eventually you can do your thing, because you'll take whatever you learn, you can take it for a life, as a life skill.
Wow.
So that's the approach I take from the outset. So there's no because I'm learning from experience. I mean, I don't like it when they come in demanding this, that, and the other. But I'll take, that's why I spend 2 hours with them. So let's talk about it.
Yeah.
What is your conception about what medications do or don't do? I had a family the other day who had allowed their psychotic son to live in the basement, and they'd called me for a consult. He hasn't turned up, but he's kind of like, he's sensitive to sound, and what they were doing was walking on eggshells around him, and they've got all this HVAC change because of him, because the sound disturbs him. I said, you're walking on eggshells. I mean, you're becoming part of the problem. You're not the part of the solution. And the longer you leave psychosis untreated, this is not going to get better.
No.
But I offered them practical advice. I asked them to call adult protective services. I gave them the criteria for acute hospitalization. And if he's not, eating properly, then, but they allowed this problem to go for many, many years. And I said, oh, should we just rip the Band-Aid off, Doc? Should we just open the curtains? And I said, well, first, don't do any harm. We don't want it like a big bust up. That's not good for anybody. We want to do an intervention. You want to sit down with him. And maybe if he's willing to go to a doctor, nothing would be better. But he'd been diagnosing himself. He was convinced he had this disorder, that disorder. It's like, he'd gone into this psychotic world, and it was affecting his decision making, and his family were enabling him. But families need to be told that, right? Like I say to them, now that you know what not to do, maybe we can make some progress here, because at least you didn't know beforehand, so now you know. I'm being honest with them. Like, it's not you that's the problem. It's our decisions and our thinking that can, I'm challenging. Not
and they think they're helping. And they think they're helping.
I think they'll be open to. My approach has been. I think that approach typically works, because the family's very invested. Then they ask more questions, and then they're engaged, and you give them practical advice. You just say, look, this is what to do first. No point doing psychoanalysis on somebody who's psychotic. Okay, it doesn't work. They say, oh, well, does he have to do the medication? Can he do therapy? I said, not for this disorder. So you kind of educate. They're like, please ask me questions, because I know how this works. I've done it for years.
Mm-hmm.
I think my experience. You can take my advice or leave it, but even if I'm wrong, all I'm saying is it ain't getting better. And I have sometimes use that Dr. Phil phrase. How's that working out for you? Like, it's not working right, and they admit that. So that's when you get the conversation to that level. So then, what does that take? It takes some effort. It takes some investment on our part to engage them. And then you do find they ask questions, the right kind of questions. They're really, really curious. I like that. That's when you take the conversation to the right level.
That's when you can get to somewhere where you can help.
Yeah. You have
So
to practice it. You have to buy it. I told him I can't do it without you. I have to have your buy-in.
Dr. Anand, this has been a great conversation. I want to thank you so much for joining us. Before we kind of jump off, is there anything, did you want to share your channel, or you said you had a YouTube page?
I have a channel. I don't think I'm going to become a billionaire tomorrow. I'll still have my day job. So I do this more as a public service thing, because based upon what the things I've told you, I do explanations of basic disorders like anxiety, depression. I do one on bipolar disorder this week. And I talk in the way I've just been talking here.
Well, how can people find it, though?
Helpful. Yeah, so it's Summit Anand. It's my first name, last name, MD. There's a comedian on there, and there's me. I'm not the comedian. He says his videos in between mine, and I'm like, I start shaking my head in my hands, like, oh my God. But I tell people put Sumit Anand, MD, SUMIT, last name Anand, ANAND, MD, and it'll pop up. And I enjoy doing it because I enjoy educating. I'm a teacher. Zeus knows this about me. I'm a teacher who loves his job, who loves his profession, and who loves the conceptual and humanistic aspects of what we do. And so I just talk about that because I've got experience. I don't need a script. I just talk about it. And I think
I'd love to have you on. I'd love to do another show, like even if we're like pick, a more specific topic or whatever. But Doctor, I'd love to have you on again. I mean, it's been a great conversation.
I'll just give you my 2 cents. I mean, again, I give you where I'm coming from. I'm happy to engage in any discussion you wish. I find this a fascinating format.
Awesome.
Yeah, Doctor, I would like to we can discuss maybe like a series on different conditions and then treatments, and we can go through that. I think I'd be
glad to do that. I think we need to be the change we want to see in the world. If we can educate people, help people, explain things, clarify, simplify to the extent possible, let's do that.
Yeah, that'd be great. That'd be great content for the Nurses RN.
Yeah, absolutely.
Yes, I may touch base with you about being on my other podcast, Doctor.
Well, this is both.
You're going places, right?
We'll see. We're hoping.
Well, Desiree, what is it that Jack normally says around this time?
I forgot. Oh, boys, I think we've been on long enough. I think it's time to wrap it up.
All right.
Or wrap things up. Wrap things up. I don't know. And the whirly bird.
Thank you.
Doctor,
Thank you. Don't
have
go
a great
anywhere.
evening.
We're going to just stop recording.